Greetings and welcome to this latest teleconference by MS Focus. I'm your host, Chris Payne, for MS Focus, and I'm joined by Dr. Marissa Barrera, who will present treatment of swallowing disorders for people with MS, advocating for effective treatment. After the presentation from Dr. Barrera, we'll open it up for your questions and comments. Now, I'm delighted to introduce our speaker. Dr. Marissa Barrera is the Assistant Dean of Health Services and the Program Chair of the Graduate Program in Medical Speech Language Pathology at the Katz School of Science and Health at Yeshiva University in New York. She is a recognized expert on the use of modalities for speech and swallowing rehabilitation and provides clinical training courses globally. As a researcher and author, Dr. Barrera has lectured in more than 15 countries on a wide variety of clinical topics. She has several peer-reviewed publications, book chapters, and more than 80 research abstracts. She has been featured by CBS News, Women's Health, Vice Magazine, and Advance for Speech Language Pathology and MTV. Dr. Barrera is a multiple sclerosis certified specialist and owns New York Neurogenic SPL PC, which specializes in telehealth. She is a member of the Healthcare Provider Council of the National MS Society and the MS Focus Advisory Board. In 2019, Dr. Barrera was awarded the Healthcare Professional Champion Award from the National MS Society. Lastly, this past May, Dr. Barrera celebrated her 10-year anniversary for serving as faculty for the Consortium of MS Centers. We're pleased to have her join us to present on this important topic. Dr. Barrera, thank you so much for being with us, and I'll turn this over to you.
Thank you so much. It's so wonderful to be back. This is my third webinar over the course of the last few years for MSF, and I'm so proud and very passionate. If anyone here has ever attended one of my webinars, you know there's a lot of enthusiasm and passion for this topic, and I hope to empower all of you today to advocate for yourself as you are in control of your MS care. So without any further ado, I'm going to share my screen. I am going to ask that we hold questions until the end of the webinar. I'm happy to answer all of your questions. You'll have my contact information, and you'll also receive a copy of today's lecture and webinar upon its conclusion. So just a moment, and we're going to get started. All right, so as we already learned, our topic today is swallowing disorders or dysphagia. And really, this is personalized to help you best advocate for your care, and not just any care, effective treatment care. So that's what we're doing today. I'm proud to represent the Katz School of Science and Health, the advisory board for MSF, and here we go. So what are our goals? Our goals are pretty simple. The evolution of rehabilitation for swallowing dysfunction has changed a lot in the last 15 years, 10 years, and even 5 years. In the past, patients and individuals who had difficulty with swallowing were often kind of limited to thickening liquids or modifying diets or doing some compensatory maneuvers like putting your chin to your chest or turning your chin to your shoulder. And while all of that is fine and good, we have evolved in many, many ways in how we provide best care, effective care for individuals with multiple sclerosis. So today, as a team, we are all going to empower ourselves to better understand, first and foremost, what is swallowing dysfunction, better known as dysphagia. We're going to understand some of the more advanced treatment options outside of the world of thickened liquids and chin tucks and head turns. And most importantly, I'm going to give you these little moments of advocacy so you can go to your healthcare provider, your doctor, your nurse practitioner, your PA, and your rehabilitation specialist and say, hey, I know this is available. I want to seek this out for myself. So I think that's really, really important. And let me disclose that I am probably one of the worst patients on the planet Earth. And why am I one of the worst patients? It's because I know a little bit about myself and I know a little bit about healthcare. And that doesn't really make me the worst patient. It makes me a smart patient. So that's what I want you all to leave here today with. Going to your next follow-up care and having a little bit of the lingo and the talk and the knowledge to give the trajectory of care that you want. So let's get started. So why is eating and drinking so important? Well, first and foremost, it's how we receive our nourishment. This is essential. We need calories and we need fuel for our bodies, for our brain, to heal ourselves, to participate in rehabilitation, to get up and just be a part of our daily activities, right? So nourishment is essential. It's the #1 reason why we have a swallowing mechanism system. The second thing, it's the primary route for many of our medications, our pharmacological interventions, if you will. So because of that, we need to make sure that this system from our lips down to our stomach is intact and that things are moving sufficiently and most importantly, safely. And then the third thing is its social aspects. Have you ever been to a birthday party, a wedding, a holiday, Eid, Sukkot? Choose a holiday across any religion or any culture and think about, when do we not talk about food, have special foods, restrict foods, reintroduce foods? So there's a huge social aspect, being a part of life that includes eating and drinking. So what is swallowing? So swallowing, simply put, is the act of moving food from our mouth down to our stomach. It needs to be timely, and it includes the movement through our oral cavity or our mouth, our pharyngeal cavity, which is sort of the back of our throat, down to the beginning of our vocal cords, and then our esophagus, which is just a fancy word for food tube. And this timely movement, this cohesive, unified movement, is our goal, for it to be safe, to go where we want it to go at the rate in which we want it to travel. So it's moving this material from our mouth down through our gastroesophageal junction. Swallowing is incredibly complex, and we take it for granted because for many of us, we don't have to think about it. It happens upwards of about 1,000 to 1,200 times per day without incidents. But when there is a disruption in swallowing, we know pretty quickly. So swallowing involves our behavior, our interaction with foods. It's a sensory act. We know if it's hot, if it's cold, if it's sour, if it's off. It's a tremendous motor act, and we'll talk about that coming up. It requires us to have awareness, cognition, ideally visual recognition for foods and liquids as well. So ideally, we would want all 5 of these behaviors and situations to be intact and us to have optimal swallowing. But really, swallowing also largely revolves around our ability to have a physiological response to food. Think about, if you enjoy a good steak on the grill, what does that mean? You smell the steak, you get excited, you have your, a lasagna coming out of the oven or cookies that are being baked. It changes our readiness to receive food. And that's through the process of salivation and the very important enzymes that help us trigger a swallow. So swallowing can be broken down into about 4 essential phases. So here we're going to follow this green mass. This is what we call a bolus or a ball. It's a solid mass of food or it can also be a collection of liquid. It could be something you're drinking, your coffee, your tea, your soda, but it can also be your own secretions like saliva. So in the oral preparatory phase, we're preparing the bolus, we're entering our mouth, we're beginning to chew the food, we're using our jaw, our lips, our tongue, and we're kind of moving it back and forth between our tongue to our teeth and in the side of our mouth. We call this the lateral sulci here, and we're moving it front and back and front and back and side to side and side to side to create a cohesive bolus. Then when we're ready, we're going to trigger a swallow and we're going to move that bolus right towards the back of our oral cavity. This is what we call our soft palate, and this is our back of our tongue, and we're going to move it back here. And just as it passes some structures in the back of our oral cavity called the fascial arches, everyone could open up their mouths and take a look in the mirror and find them in the most back portion of the posterior portion of your oral cavity. This is when kind of the magic happens and the swallow is triggered. Then it is no longer in our personal control. That bolus is rocking and rolling. It is moving through our pharynx. We are hoping that our epiglottis is going to flip over and protect our airway. We never, ever want food or liquid or anything for that matter into our airway. And here our food tube is going to open up in that final stage, the esophageal phase, and allow that bolus to be squeezed all the way down into our stomach through a sophisticated peristaltic wave. Think about the food coming at top and being squeezed and stripped all the way down to that lower pyloric valve. So this complicated system takes place in about 1 to 1.5 seconds. So as you can think and really begin to imagine, this is complex, it is fast, and we really want to make sure it's accurate, because what's at stake? Food, liquid, saliva, God forbid, pennies, crayons, you name it, entering our airway, which could be devastating and life-threatening. So here is a video of the ball of food being brought into the mouth. We call this reception, masticated, the preparation, and then moving through that oral cavity up and around our airway that is closed. So occluded just means closed, and we want that airway to be closed at the moment of the swallow, so nothing that doesn't belong there gets inside. So let's take a look at this animation. Here we have some material entering our mouth. We're stripping the spoon, and here comes that motor chewing. The tongue is coordinating with the muscles in the side of our mouth. The tongue is keeping that ball of food between the tongue and the teeth. It's becoming more unified. We're breaking down any of those chewy, hard materials. This right here is our epiglottis. We want this to flip upside down at the moment of swallowing. Here it comes. The epiglottis is flipping over, our airway is occluding, and that food, that bolus, is getting squeezed down into our food tube. Everything is safe. The airway opens up, and the epiglottis comes back up into its neutral position. So many things are happening here to protect our airway. Our airway is the most essential thing. We are maintaining integrity. So as you can see, swallowing requires a sophisticated orchestration, if you will, of about 50 pairs of muscles and 6 cranial nerves. This is a highly, highly delicate and sophisticated act. And here we're going to take a peek at looking at now what we call a lateral view. If you were to take me and kind of put me through a buzzsaw and look through the side, we're going to look laterally to see where that ball of food is going. So let's take a moment and look at some important anatomical features. So here we have our lips, our teeth, we have our hard palate, our tongue, and here's our soft palate. Okay, then coming down here, we have some other structures, but this one is very important. This is called our epiglottis. We just saw that flip over to protect our airway. Here is our airway. This is the beginning of our vocal cords. Here we have our tracheal rings, and back here, super, super thin, this is our food tube or our esophagus. And we're very interested in watching the hyoid bone, which is really the only bone in this structure, move. And we're going to point it out in an upcoming animation. But let's take a look at swallowing now from the side instead of the bird's eye view. Here's the tongue. It is propelling the bolus downward. Here comes the flipping or the inversion of the epiglottis. The whole system is coming up and forward. It's getting propelled downward. The airway is protected and the food tube is receiving that bolus. And woof, we are clear. There's nothing we don't want in our airway. So now that we know a little bit about normal swallowing, let's talk a moment about dysphagia. This is disordered or atypical swallowing. And dysphagia actually comes from its Greek origins, meaning dys and the inability to move food from the mouth to the stomach. So dysphagia, also known as swallowing dysfunction, can occur in any age group from itty-bitty neonates to older adults, and it has no bias for gender or for culture. It can happen to any one of us, and all of us have experienced moments of abnormal swallowing. Just yesterday, I was on the phone with my sister and I was talking, which I shouldn't have been doing, while trying to eat a piece of a cookie, and my food, quote unquote, went down the wrong pipe. And I started coughing because my body responded and recognized that something foreign did not belong. So we would hope that our systems are intact, and it tells us as a trigger that cough is my body telling the outside world, I'm trying to clear something out of my airway to protect the integrity of my lungs. So because it can happen to any one of us, and there are certain disorders and diseases where dysphagia can occur in higher instances, it is a global health concern. So you may be asking yourself, Dr. B, well, what are some of the things I should be aware of? So first and foremost, throat clearing, coughing. Any type of abnormal volitional cough. Volitional cough is essentially having the ability to cough on cue. It's so important. If I said 1, 2, 3, cough, all of us should hopefully be able to cough kind of instantly with some force to clear our airway. Our voice can change as a symptom of swallowing dysfunction. Chronic respiratory illnesses, the need to swallow multiple times, right? One ball of food requiring 2, 3, 4 swallows, prolonged meal times, sometimes the appearance of low-grade fevers, weight loss, right? Unplanned weight loss can be very problematic. Malnutrition, dehydration, this feeling that something is stuck in the back of your throat and the constant throat clearing. This is something called globus sensation. It's this idea that something is back there when in fact, perhaps nothing may be back there. You're modifying your diets. You've eliminated steaks and certain chickens from your typical meals now because they're, too hard to maneuver or manage, or they make you feel uncomfortable, or they're fatiguing because the amount of chewing needed. Just difficulty getting that swallow started. Sometimes losing food through the lips, through the nose or in the back of the throat without your conscious effort or wanting to have those liquids or foods move in those directions. And sometimes some of our clients report the need to regurgitate either during or after a meal. So these are some of the common signs and symptoms. You can use this as your own very personal checklist as you think about your own dysphagia or thinking about a loved one who may or may not have swallowing disorders. So here we're going to look at an actual, what we call video fluoroscopic swallowing study. This is something that many of you may have experienced. And if it's new to you, let me walk you through it. The only way we can diagnose swallowing dysfunction is by having an assessment where we can actually visualize food moving through the system. You cannot come to my office and meet with me. And even being a pretty seasoned clinician, an MS specialist, a swallowing specialist, not even I and my colleagues of equal credentials can diagnose swallowing dysfunction without physically watching the swallow and looking where that bolus of ball of food is going during the active deglutition. So this is how we do. We've got two main methods. This is called the modified barium swallow study or the video fluoroscopic swallowing study. And the other way is when we put a thin camera through the nose and it hangs out in the back of your throat and we're kind of hovering over your airway. These are the two main methods that we use to diagnose swallowing. So here is my client. You're probably going, what am I looking at? This is the cervical spine. This is the back of the skull. And right here is the hyoid bone. This is so important. Hold on to this bone. We're going to talk about it later about the rehabilitation of swallowing. The hyoid bone is the only bone in this swallowing system. And during the act of swallowing, it is going to, when it is being influenced properly by muscles and nerves, it's going to move up into your anterior neck and move forward. So we want this up and forward tilting movement. This is essential movement. So the first thing I do as a clinician when I see this X-ray, if you will, is I go, boom, here's my hyoid bone. Now I can begin to orient myself to what else I see. Here we have the jaw or the mandible. We have some teeth here, and this is our soft palate. And here we have the entrance of the airway or the trachea. And over here is this teeny area here is the beginning of our food tube. So let's look and see how fast it takes to do a normal swallow. Okay, here are some liquid swallows. Look how fast. But look at that hyoid bone. Just stare at this bone. Look at that movement. Up and forward. Okay, this is very important. The movement of this bone and the flipping of the epiglottis to protect that airway. It's interesting. It's all taking place in a matter of a split second. So this is what we would want. This is quote unquote normal or within normal variation for swallowing. Fast, accurate, and we don't see any black residue entering the airway because the epiglottis is covering it, the vocal cords are closing, and we're sealing off that delicate airway. But what happens when food or liquid, quote unquote, goes down that wrong pipe? Something that we have all experienced. This is sort of the worst case scenario. And let me tell you why. As I mentioned yesterday, when I was chit-chatting with my sister and food went down the wrong pipe, I immediately began to cough. She asked me, "Are you okay?" And I went, indicating that something had entered either on top of my vocal cords or in my airway. But for many patients and colleagues, they don't cough. and people go on their merry way, unbeknownst to them, innocently not knowing that food and liquid is dumping into their airway. This is what we are trying to protect. This is what we call silent aspiration. When this happens repeatedly, this is when somebody can develop a pneumonia, an infection in the lungs that can be, quite frankly, deadly, right? And certainly debilitating. So let's look at silent aspiration. So what are we looking for? First and foremost, here's that hyoid bone. We're getting acclimated with our anatomy. Here's our airway. Here's our jaw. And now we want to make sure that no black substance enters this tube here. Let's look what happens for this individual. So food is entering their mouth. And already, whoa, we've got black spillage into their airway instantly. And the black, it represents food mixed with barium, which is radio opaque. It is in fact sitting on top of the food tube and it is spilling. They're trying to swallow. They're working so hard and it's spilling forward into their airway and they're not coughing. You don't see, these are their shoulders. You don't see them moving. Oh boy, there's another one. Now, this is very concerning. Every swallow, this gentleman has food and liquid, in this case, we'll just call it a bolus, entering their airway. Now, if they were sitting next to you at the dining hall, at your local Panera, or at your pizza shop, here comes a bad one. I'm not going to lie. This makes me cringe a little bit as a clinician. Whoa. You would never know that your friend, your loved one, your client has all of this foreign material entering their airway. And this is why it truly is what we're trying to avoid. Every single day we get out of bed as healthcare professionals, and our job is to avoid this constant accumulation of food entering our airway, which is toxic, which can be deadly, certainly can cause pneumonia, which is something we want to avoid, and you have no idea it's happening. So this is what we're going to learn today. How do we prevent this? What exists to prevent this type of silent aspiration or even overt aspiration with coughing? So what's the likelihood of this happening with somebody who is living with MS? Well, first and foremost, there's about 18 million adults in general in the United States who have swallowing dysfunction. And the prevalence of swallowing dysfunction for persons with MS or PWMS is very conservatively estimated to be about 43%. There's an occurrence of about 40% of silent aspiration for persons with MS. Let's just take a moment and think about that. What we just saw in that previous video of that VFSS occurs about 40% of the time. This is what we have to work together to avoid, for you to advocate and for people like me to help prevent. Because if I don't know and you don't know what's happening, it is very, very detrimental. So we also know that sometimes MS and dysphagia can even occur with low levels of impairment, low levels of disability. You can, in fact, see swallowing dysfunction. The prevalence of swallowing challenges increases as the disease progresses. About 65% of persons who are classified as severe disability and multiple sclerosis have the likelihood of swallowing dysfunction. And we also know that there is an association between your imaging. If you should be talking to your doctor about where is the lesion load, where is the highest accumulations of lesions identified on MRI. And we do know that there's an association between multiple sclerosis, lesion loads in the brainstem, and the link to swallowing dysfunction in about 34% of persons with MS. So we've got some strong numbers here to guide us in advocating for better swallowing care. So MS and swallowing, clearly, as we now know, it is complex. It is deceptively complex unless something has gone awry. In particular, for persons with MS, we see this coexistence, the coexistence between challenges and impairment in swallowing and lesions in the brainstem, lesions in something called the cortical bulbar tract. We can see that there's a paresis in cranial nerves. We know that there's 6 cranial nerves responsible for swallowing. When we see changes in those nerves, it can change our swallowing function. Disorders of the cerebellum, the brainstem, and even cognitive dysfunction, right? So today's topic is not a dementia, but why do people with dementia, which is severe cognitive impairment, often have challenges in swallowing? Well, when you lose the ability to recognize food, to understand what to do with it, how to maneuver it, it can change the way that we swallow. So all of these coexistences leads to impaired control over the swallow, changes in the biomechanics, your ability to influence the flow of that bolus, and that reduces the safety of the swallow. Remember, our goal is to keep the airway clear all day, every day. So it's also important to know that dysphagia itself is not a disease. It is a medical condition. It is a medical diagnosis that is associated. It's paired with several other underlying diseases, many, too many for me to name on this webinar, but multiple sclerosis being one of them, stroke, Parkinson's disease, ALS, many, many others, cerebral palsy, PSP, multiple system atrophy, and so many others. And this is why, here's your first advocacy moment for today. Check out that pink arrow. It's telling you, pay attention here, everyone. It's important to know that you need to advocate for consultation with a medical speech pathologist, because unfortunately, many, many patients are not getting the evaluation and the referral and the treatment that is available to you. So under referral to people like me and my colleagues who identify as medical speech pathologists is largely because sometimes you might not recognize the signs and symptoms of swallowing, but I've already given you 15 of them today. So hopefully you will hold on to that and have an increased sense of awareness for those symptoms. But sometimes doctors and PAs and nurse practitioners, although they are leading our healthcare, sometimes they don't know, or they may be so focused on taking care of your spasticity or your fatigue or neurogenic bowel and bladder or anything else, your mental health, that they may forget to ask about your swallowing function, which is so essential for your livelihood. And also, a lot of the different surveys that we use to assess multiple sclerosis don't ask questions that are sensitive to swallowing dysfunction. So there are a lot of shortcomings, unfortunately, in the system, but you can advocate for something different. So first things first, you can screen for your own swallowing dysfunction. So what is a screening? A screening is a simple yes, no. It is not a diagnosis. It is not conclusive. It is simply something to kind of get you thinking that there may be a challenge to your swallowing. So this is something called the repetitive swallowing, saliva swallowing test, the RSST, okay? So this is something you can ask a loved one to do for you. Here, individuals are asked to swallow their own saliva, their own secretions, as many times as possible within 30 seconds. And then via light palpation, which means light touch on the larynx, we're going to put our hands very gently across our neck with our pointer finger right at that 90-degree angle. This is typically where we find that hyoid bone, that very essential bone for swallowing. And we're going to gently drape our fingers across our anterior neck. And then we're going to ask our patient, or you're going to have yourself swallow, or your loved one is going to assess. I do not recommend doing this to yourself, but having a friend, a colleague, a loved one, a caregiver, just gently feel, and you're going to swallow as often as you can within 30 seconds. I have some data for you in a moment, but before we talk about that, why is this a great way to just screen, quick and dirty, if you will? Because it's safe. We're not putting any food in someone's mouth. We're not putting anything foreign that doesn't belong in the mouth. You're using your own secretions. And interestingly enough, there is some scientific evidence, what we call a high correlation between performance on this very simple RSST task and observing aspiration on that video fluoroscopic exam. That's that movie we just looked at together. So there is a correlation. We are not just randomly doing something. This is something that we have studied and we have data for. So once again, here in this picture, they're using 2 fingers. Not my preference. I'm more of a pointer finger to pinky type of gal across our anterior neck. You're going to swallow as often as you can within 30 seconds. All you need is your own secretions and a stopwatch or your iPhone or your Android. Count down from 30 seconds and count how many swallows. Very light touch. Keyword is light touch. We don't want to do anything hard or heavy that would change the normal swallow. And we have data here. Here's some interpretation. If you have swallowed fewer than 3 times within 30 seconds, this may be something you're going to want to mention to your healthcare professional. You may want to reach out to a medical speech pathologist, find somebody who can further look into this for you. So this is not a diagnosis. This is a simple screening that says, hey, 3 times in 30 seconds is kind of low. You saw how fast somebody can swallow in some of our earlier videos. So we're going to want to jump in there and get to people like me and my colleagues to go ahead and look at that. And we have some data that says less than 3 swallows could mean that there are aspiration events or food or liquid going down that wrong pipe. So we want to get in there and make a quick and fast intervention. And the next thing you can do is you can go ahead, go online and print out something called the EAT-10. It is available online through this link or via PDF, and you will have all of these available to you at the conclusion of our webinar. And what's great about the EAT-10, it's translated into several languages, and it takes less than 5 minutes to administer. And this is a fully autonomous or self-administered kind of probe into your swallowing. You can do it alone, you can do it with a clinician, you can do it with a loved one, and it's going to give us symptom-specific outcomes for swallowing. And there's 10 statements, that's it, 10 statements, and you're gonna rate yourself on a 0 to 4. 0 being A-okay, absolutely no problem or concern, and 4 being something of serious concern and problem. And then we're going to tally that up and get a number, and we'll talk about that in a second. And what's great about the EAT-10, it is a valid outcome measure. It's something we can do repeatedly. Typically, it can be repeated, reading this assessment and judging yourself on these 10 statements anywhere from 60 to 90 days to track your progress, whether you're in therapy or you have concerns for swallowing. It's something that can be done several times per year to look at your performance over time. So here's the actual assessment on the right-hand side. Once again, 0 to 4 rating. You can say my swallow problem has caused me to lose weight. Swallowing liquids takes extra effort. Swallowing is painful. Swallowing pills take extra effort. When I swallow, sometimes food gets stuck in my throat. I cough when I eat. Swallowing or mealtime is stressful. Very, very simple, but highly predictive. Look at this beautiful research. You can't take the Ph.D. speech pathologist out of me. Even though I'm proud to be a clinician, the researcher and the assistant dean of health sciences in me says, what is the data? What is the data? Well, here's the data. A score of less than 3 can be indicative. If you have a total score of less than 3, it can be indicative. Pardon me, less than 3 can be indicative of oropharyngeal dysphagia. But scores of 15 or more likely to indicate that somebody's going to aspirate, 2.2 times more likely. So looking at that rating scale is very, very, very important. So scores greater than 3 is likely indicative of oropharyngeal dysphagia. And scores of 15 or more can lead to a predictive value of 2.2 times more likely to aspirate. So once again, this isn't the hard all, say all, end all, be all, but these are predictions. It's not a diagnosis, but these are predictors that something may be going awry. So go ahead and put these on your own clinical tool belt and advocate that you sit down and take some time for yourself to assess your own swallow. So why is advocacy so important? Why am I saying to screen your own swallow, or to collaborate with your nurse or your home attendant or your spouse or your partner? Well, as you saw in that video, there is no room for error in terms of swallowing. The stakes are so high. What are the consequences for swallowing dysfunction? Well, first and foremost, choking. Right? Choking, unfortunately, can lead to death. It can compromise your airway. The need for tracheostomy, malnutrition, dehydration, weight loss, reoccurring respiratory illness. In severe cases of swallowing, there may be a need for a feeding tube through the stomach, through the mouth, through the nose, through the jejunum. There's many different places that sometimes our loved ones require artificial feeding and nutrition, but ultimately that aspiration can lead to respiratory distress and pneumonia. And unfortunately, pneumonia can be deadly. So this is very important information. This is why we screen, and this is why you're here today advocating for your own best personal care. So now that we've screened, and perhaps you have a bona fide dysphagia diagnosis. So you've had one of those tests I mentioned earlier, either the modified barium swallow study or video fluoroscopic swallowing exam. That's eating food or liquid that's mixed with barium to watch it move down your food tube, or the FEES, which is that little endoscopic swallow camera down looking bird's eye view. This is what you need to have a diagnosis. Okay, so we've done it. Dr. B, I have my diagnosis. Well, now it's time for you to advocate for your own therapy. So when you are seeking therapy, which you can interview therapists, you don't just have to go to anyone. You should always choose an interdisciplinary medical team of people that you like, that you feel passionate about, that get you and understand you. So this is an interview process. When I meet a patient for the first time, I never assume that they're going to stick with me. I would love for them to stick with me, but I don't assume that, because you have the right to choose your healthcare providers. Let that resonate, everyone. You are in control. So when I go to a doctor's office, and like I said, not everyone's favorite patient, I know a little too much. That's okay. I'm going to say, you know, Marissa, Dr. B, I'm looking for a healthcare provider to help me with the rehabilitation of my swallow or my speech. And I want to make sure that we're going to be focused as a team on these 4 important principles. And here they are. These are the 4 principles you should be advocating for a part of your rehabilitation plan. And the first thing we always want to do is restore function. That's my first goal, is to restore as much as function as I can to your system, to as close as normal. Sometimes it's a little, sometimes it's a lot, but the restoration of function should be the #1 priority that you're working on, a part of your interdisciplinary medical team. 2 is going to be managing symptoms, reducing the coughing, reducing the throat clearing, right? Reducing the meal time, improving the speed in which you can initiate the swallow, protecting that airway, that is so, so important, and optimizing nutrition. So these are the 4 pillars for good efficacious rehabilitation. So use them when you interview your rehab professionals. Then there's so many different treatment options. I call this your dysphagia menu. It's kind of like a buffet table. If you were, in fact, at an event, perhaps a baptism, a bar mitzvah, and they have a buffet table, what are you going to do? You're going to get your plate, you're going to get online, and you're going to systematically move through each table. You're going to look at the salads, you're going to look at the cheeses, then you're going to move to your meats, you're going to choose some pasta, perhaps a starch, then you're going to get to your good stuff, your desserts, right? Everyone chooses something different to be on their plate. Rehabilitation is the same way. When you go to your rehabilitation professional, these are the 4 buffet tables, if you will: compensatory, medical, therapeutic, and modalities. And you want that rehabilitation professional with you as their partner to choose what is appropriate for you and your body and your swallowing. It's not one size fits all. It's not a cookie cutter, right? Everyone is going to have something different. The 3 things we're going to talk about briefly that are a little bit more advanced options. It's not this. This is the stuff that everybody kind of does, this compensatory stuff. I told you that this webinar is about, advocating, empowering you to know some more of the sophisticated stuff. So the sophisticated stuff is expiratory muscle strength training, surface electromyography, and ultrasound. So let's do just a quick little overview. So on our buffet table menu, we see therapeutic exercise, right? Right here. Let's talk about how do we exercise our lungs, our intercostals? How do we protect this airway and keep food and liquid and junk, if you will, out of our airways? This is the #1 goal, right? It goes back to our pillars of rehabilitation. So one of the ways we can do this is through the therapeutic approach of respiratory muscle strength training. It's called RMST, and it is a phenomenal technique. It is one of the most underutilized exercise-based interventions that is literally a huge, huge research body of effectiveness, right? Once again, I'm wearing both hats right now, clinician and PhD scientist, put them together. This is really the marriage of those 2 philosophies: great patient care and lots of effective literature. It is fantastic because it targets both improving inhalation, the taking in of air effectively, as well as expiration, which is what we use to talk, right? And it's what we use sometimes at the moment of swallow. We stop breathing for a second on that exhalation. And this therapeutic technique helps us improve speech production, which is not the talk for today, but we certainly can't, forget it exists. It helps improve the cough, which is so important because coughing is our body's response to get stuff out of the airway and ultimately swallowing. So this is so important. So you want to advocate for RMST when appropriate. What's the procedure? The procedure is simple. It's inhaling, exhaling in a very controlled manner into different types of devices. This could be a spring-loaded device or devices that have different size air ports, and it provides different resistant loads to our respiratory musculature, our skeletal musculature, and that can in fact help improve coughing, speech, and swallowing. So interestingly enough, even though RMST per se is not a swallow exercise, we're not actually engaging in the act of deglutition to improve swallowing, but there is an abundance of evidence that this is an effective transference, and it's going to help move this exercise into actually improving respiratory strength training, and that within itself is going to facilitate swallowing. Such a rich body of literature, even specific to multiple sclerosis. I have some of these research articles cited here. Don't take my word for it. I'm here to speak for the science, and it is an extraordinarily effective technique. This is one of the devices. I have no financial or relationship with these devices. I'm speaking and sharing them with you because they can be effective in the rehabilitation of respiratory strength. This is called the breather. The breather works for both inhalation, exhalation. It's pretty cost effective, anywhere from $28 to $35. And as you move the dials, you can see there's a dial here set from 1 to 6 for inhale and the same for 1 to 6 for exhale. You're breathing through different sized little holes. Imagine breathing through a coffee straw, like a stirrer. Think about all that force to blow all that air through this super narrow hole. And then imagine blowing through a McDonald's milkshake straw. That's the biggest straw I've ever encountered in my life. Super easy, less resistance to the force. So breather is one of the intermediate resistant devices using airports. Okay, it is excellent device for anybody who may have neuromuscular diseases, but it's also used by athletes as well. Singers, anybody who really needs to work on their breath support. Those different airports are going to provide different various levels of resistance. Once again, think about breathing through different size straws. It has been shown scientifically to improve that respiratory support, to not only improve speech, but phonation, articulation, and of course, our topic of interest today, swallowing. It can strengthen the skeletal muscles of our neck, as well as our pharynx and our larynx. And there is even research that says it can help reduce the likelihood of aspiration. Once again, it can, didn't say it will, but for certain clients and certain individuals, it can reduce the likelihood of having that aspiration event, food or liquid entering the airway without your consent. And that is what we're trying to avoid. So this is a huge part of your rehabilitation advocacy moment. Now, some of the devices are different. They are spring-loaded. This is a spring-loaded. There's a metal spring in here. This is one device called the EMST. Once again, I have no financial relationship with this device. This is a pressure threshold device. It is significantly harder to move the dials here to engage those intercostal and skeletal muscles for respiration. Okay, we use the device to increase the progressive load or the resistance to the force throughout your training. And that excessive force through the continued airflow of exhalation, once again, can help improve cough, airway protection, ding, 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 so important, and breath support. So I have some videos linked here that you will have access to upon conclusion of our webinar that you can go ahead and take a look. And I've even included a sample training protocol. Now, I'm not encouraging you to do this on your own. You definitely want to reach out to a medical speech pathologist and your healthcare provider. But a common protocol used is for 5 weeks, 40 repetitions a day, for 5 days a week. So this is clearly not taking too much time out of your valuable day, and it can really have a huge, huge impact on your swallowing safety, improve swallowing, improve airflow, improve airway protection, breath support, phonation, and even your speech. So I highly encourage you to look into this with your medical healthcare provider as your partner. So there's different RMST, respiratory muscle strength training devices. Here are some of the more common devices and the levels of difficulty. So the EMST 150, the blue device that is pictured in the previous slide, that is really the highest level of resistance. The EMST 75 is often referred to as the light. This has moderate resistance. The breather, which is pictured in our previous slide, it is the blue and white device. It also sometimes appears black and orange as well. They also have a moderate resistance, but using air ports versus spring-loaded. And the easiest thing Low resistance is an incentive spirometer. So if you've ever gone to the hospital and you've had any type of minor procedure and they want to keep your lungs moving, they'll give you that kind of tube with the ball at the bottom and they say blow into this X amount of times as per doctor recommendation. And you're going to want to go ahead and do that. It's the lowest resistance, keeping that ball up and down, but it still is a form of RMST. So lots of options here for you to explore and to advocate for. And moving forward, we're going to talk about 2 modalities. And I love this saying, I can see with sound. What's your superpower? And that is the power of sonography, which we'll talk about in just a second. So now we're going to talk about 2 brief interventions for multiple sclerosis and swallowing rehabilitation. That is even more kind of scientific and a little bit more, I guess you could say fancy bougie, if you will, but they are also grounded in evidence. So let's explore. So what are modalities? Modalities is taking a therapeutic technique and using it in combination with something else. And it's the combination, it's the marriage of using ultrasound and a really hard swallow, or ultrasound and certain tongue and lingual placements. It's the marriage of the 2 that enhances rehabilitation. This is a form of a modality, and this modality in combination with other forms of therapeutic exercise working together as a team can elicit brain plasticity. Wow. And when we elicit brain plasticity, that can facilitate recovery of function. And if you go back to Dr. B's 4 pillars of rehabilitation, what was the number 1 thing? Who remembers? Number 1 thing was to restore function. So everything that I'm presenting is very structured. Everything is supporting the greater goal of improving your function, improving your airway, right? Facilitating as close to normal as possible. So modalities are a huge part of your rehabilitation program. It's going to allow your clinicians that you work with to target those 6 cranial nerves and those 50 pairs of muscles, sometimes better than conventional rehabilitation by itself. And it's going to help us elicit or kind of awaken our organization of our brain. It's task specific. It provides you with this kinesthetic, this awareness for your body and space and time. It is very, very, very powerful. So let's explore 2. Biofeedback. You may have heard this term before. Biofeedback is actually an umbrella term. It's a catch-all term. It's a term for techniques in which patients or you, individual, are presented with real-time movement, real-time visual and auditory representation for your muscle efforts, right? So as you swallow, this kind of mountain is drawn upon the screen and it kind of represents your muscle firing, right? So that's an example of biofeedback. Sometimes patients go to biofeedback for psychological and other types of awareness techniques to being aware that they're overusing a certain muscle group or overthinking something. Biofeedback is used for traumatic brain injury rehabilitation as well. It is a commonly used technique for giving you data about your effort, whatever that may be, at this exact moment. Okay? And the 2 forms that we use a lot in medical speech pathology, and specifically for the rehabilitation of swallowing for persons with MS, is surface electromyography, which is a incredibly non-invasive, meaning you feel nothing, you have no pain, nothing at all, nothing to make you uncomfortable. It's a non-invasive study of how your muscles are firing through contraction and then giving you data. We're going to explore that in a moment. And then ultrasound, which is a non-invasive way in which we use sound waves to create pictures in our oral cavity or just in our oral pharyngeal cavity to help you conceptualize what's happening here, right? So this is very, very meaningful. So first and foremost, what is surface electromyography? Surface EMG is actually very, very simple. It includes 3 total electrodes, 2 electrodes on the muscles in which you're interested in studying. So for us, and I have a picture coming up, we're interested in learning about the swallow. So we're going to often place electrodes just underneath the chin. We call this the suprahyoid region. Remember that hyoid bone? Right? Supra means above. We're interested in the suprahyoid region. 2 electrodes will be placed in this region of interest, but perhaps you can do a bicep, tricep, quadricep. If the muscle is superficial, meaning towards the surface of the skin, we can measure it through surface electromyography, okay? So your PT counterparts may be using this with you as well. And then 1 additional electrode on a connective tissue. And what the device is going to do, this little teeny tiny box that's measuring the muscle firing, it's going to, without your thought, measure these 2 electrodes here and calculate the difference of voltage against the connective tissue, the ground wire, your body versus those muscles of interest. So the analogy I always love to give is, how do you find out how much your dog weighs? Not an easy task, right? What's the easiest thing you can do? You step on the scale, find out your weight, get that number, get on the scale, holding your beloved puppy, get the new weight, and what do? To find out the dog's weight, you're subtracting out your weight. That's kind of generally the principles for surface EMG, right? We've got the 2 muscles of interest being captured and then kind of like the ground connective tissue. And in real time, this device is separating the 2 and just isolating some information on these 2 muscles of interest. It is not new. It has existed for swallowing since the 1950s, a very rich body of scientific literature. It is not controversial. It is completely non-invasive. And what's really cool is that you're not going to be swallowing 1,000 times. Surface EMG is most effective when I ask my client and I ask my patient to swallow as hard as they can, just a few times. So think about going to the gym and your trainer says, hey, Marissa, give me your 1 rep max. What is your 1 rep max on the bench press, right? Or the deadlift? That's kind of the principle here. We want to measure your muscles, giving it their absolute all. So here I may have my patient just do anywhere from 5 to 10 swallows, but at maximum effort. Leave it all on your therapeutic table, right? Leave it all on the mat, leave it all at your therapeutic table. It's all about hitting hard and heavy and measuring that maximal voluntary contraction. And what I love about surface EMG, there's no normative data. It's not like we're comparing my muscle contraction to your muscle contraction to your spouse's muscle contraction. You serve as your own reference point. So maybe on your first day of rehabilitation with your medical speech pathologist, she would collect, or he or they would collect some data about these muscles, and then that would serve as your baseline, right? And then over time in your rehabilitation, you would track going up, going down. What does that mean? So you serve as your own norm. You're only in competition with yourself. And that is very, very powerful. Here's where we would place those electrodes. We call these, once again, the suprahyoid. Here's the hyoid bone. Here's your larynx. Here's your tracheal rings, right? We are going to put 2 electrodes, 1 on each side in the suprahyoid space, and then we're going to place a ground electrode on some connective tissue. Very small, completely painless. All you have essentially are 2 surface stickers, if you will, on your skin. Here's an example of what it looks like on an actual individual. You can see they're underneath the chin, not on the neck, not on the chin, not on the face in this case, but really right in that sweet spot, that triangle underneath the chin, one on each side, measuring each kind of group of muscle movement. So the protocol would be your clinician would help clean the skin with a special skin prep pad, place 2 new electrodes right here in that suprahyoid region, place another ground electrode either on the neck or the collarbone, and then have you exercise. Remember, if you don't use it, you will lose it. Lots of exercise, awakening the muscles, and then giving you data. This is the last part of the missing link for this technique, giving you data. You're going to get data and a picture of your effort at the exact moment of your swallow. So before we talk about this, here's an example. Here's one of my favorite devices. This is the NeuroTrack or MyoPlus Pro. This is an actual example, right? This is somebody working their pelvic floor, but the example remains the same. The muscles are low at rest and firing, and then boom, the muscles are working. And you see in real time, this kind of mountain being drawn with the muscle activation. These electrodes are activating this picture on the graph. And this is actually one of my patients. The patient came to me and they were tired. They were swallowing twice. Every single time they swallowed, they were doing double swallows. That's exhausting. So I said, Mr. Smith, I just want you to swallow once. Draw one mountain on our computer screen. And I did nothing else other than let him swallow. And he looked at this picture. And you can see first swallow taking place at around 2.5 seconds. 2 very clear peaks. Boom, boom, swallow, swallow. All right, Mr. Smith, try to give me one mountain. I get 2 swallows. Okay, I appreciate your effort. Can you try to give me just one? And look, here we go. A little bit better. And then a little after swallow. And then look, magically on the 4th, or not so magically through his own effort and the use of this data in real time, here is my very lovely single swallow. Great. How did that feel? That's what I want you to do each and every time. Okay, so this is the power of surface EMG. You have data, you have pictures, you can manipulate your behaviors, work harder, relax muscles, all with the assistance of these painless little stickers guiding your muscle firing. And PS, surface EMG and dysphagia and multiple sclerosis is well understood. In this research study, we saw that using surface EMG to measure the suprahyoid muscles for persons with MS, 92% of patients showed at least one abnormality in this region associated with MS, and how they evaluated their swallowing on a scale called the Dysphagia and Multiple Sclerosis Questionnaire. So once again, I'm leading you to the science to tell you that this is something for you to try to explore within your research world. Pardon me, your rehabilitation world, using the research to guide you. And last but not least, ultrasound. Here is one of my absolute favorite things I do. Here I was in Athens, Greece, teaching an ultrasound course to speech-language pathologists. Here we see the Claris device. Once again, I have no affiliation with any of these companies, but we're looking right here. You can see the transducer here, and we're looking at the muscles of swallowing right then and there. And here is my device. This is called a butterfly. These are very accessible, relatively inexpensive ways to incorporate into therapy. So ultrasonography, once again, not new, 1970s, started looking at the research for swallowing. Yet, why I don't know, it's not in traditional rehabilitation practice for speech pathologists. So ask and advocate. Advocacy moment, everyone. Ask and advocate if ultrasound is available. It may be available in the PT department. Well, let's talk about a collaboration. PT and SLP should be working together to see if this is something that will benefit to you. It is extremely powerful modality. It is completely non-invasive. Once again, not a pain, not a prick, not a nothing. And it's going to allow us to look and visualize dynamically at those muscles in your mouth and that very important hyoid bone during the act of swallowing. So here's a little teeny tiny introduction to science for ultrasound and swallowing for persons with MS. So as I said, this is portable. It's non-invasive. There's no radiation. There's no barium. It's a very, very easy to use technique. All we're going to do is put a sound wave generator known as a transducer on the skin along with some conduction gel, and these waves go through your body. Those sound waves hit tissues, fluid, bone, and they bounce back to the transducer, and then it gets converted onto an image on a screen that the clinician can see, but so can you. And when you can see it, you can then engage in meaningful exercise. We love this technique because it's safe, it's effective. There's very few people who cannot get an ultrasound. Truly, there's like almost no to minimal exclusion criteria, which means many people can participate. There's no x-rays. And from the patient point of view, from your point of view, you love it because it's pain-free. There's no special preparations. You can eat, you can drink. You don't have to taste poorly tasting barium. You don't need a camera through your nose. It is very rich in the comfort that it provides you. So ultrasound is going to let us visualize, once again, your swallowing structures in real time, just like Mr. Smith and his double swallows using EMG. Now we're going to use ultrasound to look at those muscles in real time. We can see the bolus. We could see it moving forward. We could see it slipping back. We can observe all of this by placing the transducer, once again, in that suprahyoid region. It's not going to alter the swallow. There's no funny taste. There's no texture changes. It's not uncomfortable, right? We can use it for an extended period of time without any concern for harm. If anyone's ever had a barium swallow study, we are in quick and fast. You don't want to be exposed to radiation as minimally as possible, right? If you're having a test with the endoscopic camera, yes, we can stay in through your nose a long time, but it's not very comfortable. So we're typically moving as fast as possible. So here with this, we can use in any environment, home, clinic, bedside. I joke, New York City subway. If there's a place where there's a patient, I can use ultrasound. But once again, what are we most interested in? That movement of that hyoid bone. It's moving up and forward, because we know when it moves up and forward, it's giving us a lot of information about the efficiency of the swallow. And that's what we're targeting in our therapy. So here's a picture of the probe underneath the tongue in that suprahyoid region. Okay. And it's going to transduce through sound waves. Here's that hyoid bone. And here is the mandible. So when we're looking at the image, we're looking to find the two black bones on the image. The bone will show up black and the mandible will show up black. And then we'll see this beam of white light, which is the tongue and the hard palate. Here is an example. Ta-da! This is what you're seeing. Here's the hyoid bone being black, bone to the surface of the tongue, this white kind of rainbow, and all these different muscles, right? So the first thing we always do is find that hyoid bone, that black bone, and we look for black and black. Hyoid bone to mandible, so we know we've captured the entire surface. Once again, advocate. Use this as a part of your therapy. Interview your clinicians and say, listen, I know that ultrasound can be used to help target specific mechanisms of dysfunction like swallowing. Taub's principles of non-use, scientific beauty. Everyone's heard of use it or lose it. That really is Taub's principle of non-use. Listen, if I don't start exercising these muscles for swallowing, I'm going to lose function. So let's work together, right? And we know that using these techniques can help, once again, carry over to improve deglutition. So here's an example. We're going black to black, hyoid bone to mandible. That's the chin, right? That's the jaw. And here's that white beam of light. During the swallow, I'm going to say to you, okay, Mr. Smith, okay, Yehuda, I want you to go ahead and I want you to swallow as hard as you can. Give me your best effortful swallow and black out the screen for me. Because remember, bone is black. So when this turns black, this tells me that that bone is doing what, everyone? Going up and forward, trying to kiss the very peak of your mandible. That's what we want. We want maximum movement of the hyoid bone because that helps facilitate a very meaningful, safe, and efficient swallow. It is the precursor to a strong swallow. So our goal is maximum movement of the hyoid bone. Black out the screen. That is our goal. So here you're going to see a swallow. Once again, we have our mandible, our hyoid bone in the back, which is a little off screen, but take my word for it. And this cone of brightness, this is the tongue against the hard palate. Here's the tongue tip, preparing to swallow, and look, boom. The hyoid bone is going to come into camera and boom, black out that screen. Okay, Mr. Smith, swallow hard. Boom, very good. And if you look down here, all of these muscles are contracting. You can see how crunched and contracted they get. That's the energy that this person is putting into that maximum hyoid bone displacement. It is so simple. It is so easy. It's 10 or 15 trials in your therapeutic session, and it gives you so much bang for your buck. So ultrasound is so easy to use. There's so many things from your buffet menu that we talked about earlier today that you can combine ultrasound with. So ultrasound with a hard swallow. Maybe you've learned a Mendelssohn maneuver, different lingual placements, testing different food textures, compensatory strategies. Ultimately, we're trying to, once again, really look at that maximum movement of that hyoid bone. Perhaps you've had post-extubation vocal fold closure. That's another thing we can use, another topic for a different day. And if you have breathing issues, so we can also use ultrasound for speech and for respiration. So minimally invasive, so much value for you as the client to understand what's happening in your body so you have the best chance to maneuver and manipulate those muscles to create a normal function, or of course, striving towards normalcy. So in summary, biofeedback, which is inclusive of both ultrasound and surface electromyography, it's safe, it's portable, it's radiation-free. It provides the clinician with insight on muscle function. It provides you, most importantly, within the moment muscle function about what's happening, what you're doing correct, what we could modify as a team. And it really can help any individual with multiple sclerosis acquire those complex muscle movements by having that feedback in real time. So in takeaway of our webinar today, speech and language and swallowing function can change in the presence of multiple sclerosis. However, there are so many effective treatment techniques. No one should be having these changes to their swallowing, but of course, speech and cognition and voice. I can't eliminate those other discussion points and sitting here and doing nothing. There is a world of individual, passionate medical speech pathologists and rehabilitation professionals who want to help you gain and recover and maximize your body's ability to exercise these functions. Obviously, the skills and the expertise of a medical speech pathologist who's familiar with MS care is the best. But remember that you need to advocate for your own medical SLP consultation because my profession, sadly, is underutilized. Almost every person I've ever encountered in 18 years of MS care has said, I've been to a physical therapist, and I can count how often they actually say, as soon as I was diagnosed, I was sent to a speech pathologist and an occupational therapist to get baseline data. I can count that on like two hands. So let's make that the norm, right? Telehealth is amazing. The pandemic has brought, really robust access to telehealth. Use it to your benefit. Find people who know your disorder, who know these services, and engage with them, even if they're not local to your local hospital or rehab center. Today, I've presented many effective but inexpensive therapeutic techniques for you to consider in consultation with your rehab professional. And always make sure that you tell your clinician, I'm a part of this decision-making paradigm. I want to consult with you, and together we're going to come up with a custom dysphagia plate, right? Think buffet table. I want this customized to my needs, my disorder, my strengths and weaknesses. And that's the way that we can, in fact, work effectively. So treatment is obviously most effective by somebody who knows your disorder. If you're experiencing changes to your speech, your voice, your swallowing skills, I hope you've learned today to advocate. You can be that really bad patient. Be me, right? It's okay to be me. I'm the bad patient because I know a little and I'm not afraid to want to be a part of the equation. So advocate for evaluation and treatment. You are in control of your healthcare, and don't allow any changes to your communication or swallowing to ever withdraw you from the conversation or your social interactions, because that is you and you are an important player at the table. So thank you so much for your time. And I thank you for joining me, and MSF for hosting me. And most importantly, stay connected. I'm here to support you on your MS journey. Here are 3 different ways we can keep in touch. So I'm really looking forward to hearing your questions and answers. We have about 10 minutes. Chris, do you want to open it up to Q&A?
Yes. Give me just a second here. We are now ready for questions. If you have a question or comment, you can ask it using the Q&A button on the app, which also allows you to send your question anonymously if you choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you, and then you will be able to unmute and ask your question. Our first question is actually from the Q&A from an anonymous attendee.
Okay.
Hi, thank you. Sometimes it feels like something is closing for a few seconds. I can't swallow during that time. Is it a spasm or is it something like that? Okay,
so first and foremost, I can't tell you necessarily this is the power of being able to observe the swallow in those 2 methods we spoke about earlier. So I can't say exactly what it is, but there could be a spasm, there could be an incoordination of the swallow. Perhaps you're even feeling the moment in which those vocal cords close at the moment to protect the swallow, or even the epiglottis inverting. There's so many things it could be. It could be a spasm. It could be so many different muscle or physiological changes, but ultimately we can find out. You don't have to live in mystery. We just need to get you to have one of the 2 tests I mentioned earlier, video fluoroscopic swallowing exam or a FEES exam. And then you and your clinician together can observe it. You can report, this is what I'm feeling at this moment, and we'll see it on screen and really get down to the bottom of it. So it's possible, but I can't tell you without seeing it.
All right. Give me just a second here. We have a question here from Moya. Let me give her the opportunity to talk. Experiencing a slight issue here. Moya, can you hear us?
Hello, thank you for taking my question.
Hi, Moya. How can I help?
I'm an MS patient and sometimes I have difficulties swallowing, choking. Sometimes it's out of the blue And sometimes I find myself, while I'm eating, and sometimes I find myself choking on my own saliva.
Mm-hmm.
Now, I'm historically a mouth breather.
Mm-hmm.
Could it be that the coordination of my swallowing is getting disrupted by my
Breathing?
Yeah.
Absolutely. So once again, I can't tell you that's your exact case without having the pleasure of working with you. But absolutely, a whole reason we spoke today about airflow was the rehabilitation of airflow and improving the intercostals and improving the skeletal muscles in the neck and all of that. So yes, airflow gradients, which means airflow, the movement of high and low pressures for swallowing, is so deceptively important. I'm going to have everybody who's on the line do this little test with me. I want you to go ahead and swallow your own secretions just with your lips closed as you would naturally. I hope that's relatively easy. Now I want you to go ahead and swallow again and just have your mouth open a crack, just enough where your teeth aren't touching, and go ahead and now try to swallow.
It feels impossible.
For some individuals, that could be nearly impossible. What's the only thing we change, Moira? Airflow gradients. We need airflow to help us propel and understand the swallow. So the answer could be yes. I can't tell you yes, but it very well could be. And you, once again, if you choose to advocate for yourself, go ahead and talk to your healthcare team about, listen, I would like to see a medical speech pathologist and investigate this, because it's definitely something you can work on.
Thank you.
My
Thank
pleasure.
Thank you.
My
Thank you so
pleasure.
much, Maya. Our next question comes from Dana. She asks, tips for the dentist, saliva and reclined position make it very difficult, as well as trying to swallow with my mouth wide open.
Well, that's kind of like a follow-up question. So I think, Dana, I hope you did that little demonstration, once again, swallowing with your lips closed and then swallowing with your mouth just ajar. Now imagine you're in the dentist, wide open. Really, we've got the accumulation of secretions. You have people probing in your mouth. It absolutely can be a challenge for, persons who are quote unquote, neurologically within normal limits. But if you have changes to your speech and swallowing musculature, which are the same musculature, your speech/swallowing musculature, it can be very, very challenging. And I encourage you to definitely have a dialogue with your dentist and let them know that this is very challenging for you to do, breaking it up into smaller amounts of time, and advocating that it's very uncomfortable. You can't manage your secretions, perhaps disclosing if they don't know that you have MS, and perhaps you have some oral pharyngeal weakness that makes this even more challenging than the average person. So it very well is valid, and I encourage you to advocate.
Let me take the opportunity here to remind everyone that if you have a question or comment, you can ask it using the Q&A button in the app, which allows you to send your question anonymously if you choose. Or you can ask your question live by raising your hand. To do so, click the raise hand button or press *9 if you're on the phone. I will call on you, and then you will be able to unmute and ask your question. We have yet another question here from Teresa. She asks, I am experiencing pain in my inner ear. Is this a swallowing problem, or is this an inner ear problem?
It can, well, once again, I can't tell you exactly what it is without disclosing, without having the pleasure of working with you, but your inner ear and your eustachian tubes are in fact connected to your oral pharyngeal cavity, right? And it drains this way. So our eustachian tubes drain into our nasal pharynx and into our swallowing mechanism, and the nerves that are responsible for the innervation of our face also run through the ear, and in through the TM joint, and innervates our face. So, and this is something I personally have a challenge with myself. So yes, you can experience ear pain associated with swallowing when there are changes in inflammation to the nerves that innervate our face. They're the same nerves that innervate our muscles for swallowing. So that is a very valid concern, and it's something you should talk about with your neurologist and potentially your dentist. And without disclosing, if you have a touch of TMJ, that is a possibility as well. These are a trifecta of disorders that can coexist. Very, very, very excellent question.
I have one comment here from
Yes.
Anonymous from before. They say, thank you for this presentation. It was brilliant and I learned a lot.
Oh, well, it's my pleasure. Any other questions? We have a
Yes,
few minutes remaining.
We have a new question from Brian.
Super.
Cough drops, not with cough suppressant, seem to help me with swallowing. Is that something that can be good to use for that?
So that's a very individual thing. Some individuals report that chewing gum encourages them, although it makes more saliva, right? It also encourages them to swallow more frequently. And that's an easy reminder to manage their secretions. So cough drops, that kind of sucking, managing of the secretions, it's very similar. So that could be something that works for you. I wouldn't say yay or nay, as long as you're not silently aspirating that cough drop, which no one would know unless, once again, we did an objective assessment of swallowing. If it works for you and you're aspiration free and your upper respiratory health is strong, then go with the flow. But the rationale may be it helps you swallow more frequently, similar to somebody who uses Tic Tacs. I've seen Tic Tacs, I've seen chewing gum, Mentos, cough drops. It wouldn't be the first time I heard of such a thing being beneficial to individual patients.
And here's our last question for the teleconference.
Great.
This is from an anonymous attendee.
Mm-hmm.
I was seeing a chiropractor prior to getting an MS diagnosis. I was using a Denny roll and was noticing that I was choking less. Was this strengthening my neck muscles, and is this helpful to continue?
Can you repeat what they were using? I'm so sorry, Chris. A what?
I'm reading Denny roll, but let me spell it out for you.
Thank you.
DENIROLL.
Just give me 1 second. Okay, it is a cervical neck pillow. Okay, okay, so just in the end of the question, I apologize. Now that I've identified the tool, I need the end of the question.
Okay, the end of the question was this strengthening my neck muscles, or is this helpful to continue?
Okay, so I am not a chiropractor and I'm not a specialist in the cervical neck. However, a Denny roll, which I believe is a cervical neck pillow, is used actually for extension of the neck. It's to help decompress some of the nerves and the muscles in this area by extending and creating space. So I'm not a chiropractor. I'm not a physical therapist. I do not believe it has anything to do with strengthening in my professional scope of practice. I believe it's used for flexion and extension to actually extend and create space. Now, interestingly enough, with your head in that extended position, I've had some clients report that it's hard for them to manage their swallow because the anatomy has been now stretched out in an atypical way. They're kind of in this C position. So I can't tell you to continue to use it or to not to use it, but if you're interested in using it, I would certainly collaborate with either, an MS physical therapist or be in tune with your clinician and your physicians to see if it's something you can continue to use. But be mindful, it definitely alters the normal anatomy for swallowing, and it could in fact make it more challenging because the anatomy can't work the right way if we're not at 90 degrees, right? So everyone can feel it's much harder to swallow. My voice even changes. Much harder. So that is my swallowing a piece of advice when it comes to a cervical neck extender.
All right, and that brings us to the end of our time. If you missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access recordings, or sign up for our newsletter to learn about upcoming events. Be with us at 6 p.m. Eastern on Tuesday, October 25th, for Oscar, the MS Monkey, making appointments fun, not scary, with our host, Sherry Binns. Our sincere thanks to all of our attendees for your participation, and
Thank
especially
you.
to Dr. Barrera. Thank you so much for the time you spent to prepare and share this information with us.
It's my pleasure. Thank you all, and please keep in touch. I'm here to support you. Have a very blessed evening. Bye-bye.